I'm going to do is we're going to use this book first, right here.
Okay.
As I showed you before, T, we're going to use this book here. So I'm going to take a picture from the first case study. We're going to do about, let's see here. We're going to do about, hold on, find it. Okay, let me take a picture of this question here. And then I'm going to send it to you. Okay. Okay, let's see. Okay. Let's see. Oh, okay. A minute. No. Now, if you have where two pictures look the same, just disregard me. But I'm trying not to send you the same pictures. I think you have 3 different pictures. Okay, so you should have gotten the one that was number 80, and you should have gotten one that was number 81. Do you see it?
You talking about what you sent me?
Uh-huh.
Oh, wait a minute. Hold on. I'm getting something else. Okay. Yeah, 150 test questions. You said
number 80.
Okay, 81. Oh, wait a minute. Hold on. Let me go back. 81. This is operative. Let me do this one. This is 82 and 80. So those are the ones?
Mm-hmm.
Okay.
Mm-hmm. Okay, so start off reading number 80 for me. Start off reading that.
All right, let me get to that one. You said number 8. All right, let me see. Okay, a 59-year-old female was brought in the operating room and placed on the surgical table in a supine position. Following anesthesia, the surgical site was prepped and draped in the non-sterile fashion. Attention was then directed to the right foot, where using a 15 blade and a 6 centimeter linear incision was made over the first metatarsal head, taking care to identify and retract all vital structures. The incision was medial and parallel to the extensor hiatus longus tendon. The incision was deepened through subcutaneous underscored and retracted medically and laterally, thus exposing the capsular structure below, which were incised in a linear longitudinal manner, approximately the length of the skin incision. The capsular structure were happily underscored off the underlying osseous attachment, retracted medically and laterally, using the osteotomy or
osteotomy.
Osteotomy. And mallet, the medial eminence. Eminence, okay. Of the metatarsal bone was removed and the head was remodeled with the Liston bone forceps and the bell wraps. The surgical site was then flushed with saline. The base of the proximal phalange of the great toe was osteomized, approximately 1 centimeter distal to the base and excised into from the surgical site. There was no hemi implant used, and the Kirschner wire was used to hold the joint in place. Superficial closure was accomplished using Velcro. Do I say 5-0 or do 50?
Velcro 5-0.
Oh, -0. Okay, I just want to make sure. I didn't know if it was pronounced something differently. In a running subcutaneous fashion, the site was dressed with a light compressive dressing. The tourniquet was released. Excellent capillary refill to all the digits was observed without excess bleeding noted.
Okay. Alrighty. So this is talking about the phalanx of the great toe, osteomized approximately 1 centimeter distal to the base and excised from the surgical site. There was no hemi implant used. The Kirschner wire was used to hold the joint in place. Superficial closure was accomplished using Velcro 5-0 in a running subcutaneous fashion. The site was dressed with a light compressive dressing. The tourniquet was released. Excellent capillary refill to all the digits were observed without excessive bleeding. Okay, so they're giving a history about the 59-year-old female that was brought into the emergency room and placed on a table in a supine position. Supine is like she's laying sideways. Okay. So that was one of the important things of why they had to teach you medical terminology. When you read the case study, you have to also picture what's going on with that patient. So supine position, she was laying on her side like this, almost like a fetal position. Okay. Following the anesthesia, the surgical site was prepped and draped in a normal sterile fashion. Attention was then directed to the right foot, where using a number 15 blade, a 6 centimeter linear incision was made over the first metatarsal head. Okay, so metatarsal is the toes. Okay, so you have metatarsal, which is the feet, metacarpals, which are the hands. Okay, and if it's one toe or if it's one finger, it's a phalanx. Okay. If it's all toes or all fingers, they're known as phalanges. Okay, phalanges. Okay. Let's go back here. Taking care to identify and retract all vital structures. The incision was medial and parallel to the extensor hallucis longus tendon. Okay. The incision was deepened through subcutaneous, underscored, and retracted medially and laterally, thus exposing the capsular structures below, which were incised in a linear longitudinal manner, approximately the length of the skin of the lesion. So they were cutting into the metatarsal and the skin of it long ways. They were cutting into it long ways. Okay. The capsular structures were sharply underscored off the underlying osseous attachments, retracted medially and laterally using a osteomome and mallet. The medial eminence of the metatarsal bone was removed at the head of the remodel with the limestone bone forceps and the bell rasp. The surgical site was then flushed with saline. The base of the proximal phalanx of the great toe was osteomized approximately 1 centimeter distal of the base of the surgical site. There was no hemi-implant implant used, and Kirschner wire was used to hold the joint in place. Superficial closure was accomplished the Vicryl 5-0 in a running subcuticular fashion. The site was dressed with a light compressive dressing. The tourniquet was released. Excellent capillary refill to all the digits was observed without excessive bleeding noted. So the type of surgical incision or type of procedure they had an incision. So let's go back up to the first paragraph. Read. Okay, well, look at where it says attention was directed to the right foot. We're using a number 15 blade. Look at that. Are you looking at that?
Yes, ma'am. You told me to go. Yes, ma'am.
Okay. There. A 6 centimeter linear incision was made over the first metatarsal head, taking care to identify and retract all vital structure. The incision, so underlying incision, was medial and parallel to the extensor hallucis longus tendon. The incision was deepened through subcutaneous, underscored, retracted medially and laterally, thus exposing the capsular structure below, which were incised in linear longitudinal manner. So this was an incision. So we're going to go to our CPT book here. So the keyword already given to us was to go to our CPT book is to go in the back under incision. Okay, so an incision was made. So let's go to the back of the book and find the word incision. Do you have your CPT book?
Yes, ma'am. I'm getting it now.
Okay.
Darling.
Okay.
Incision.
Incision.
Okay, incision. I'm with you.
Okay. Now, incision was medial and parallel to the extensor hallucis longus tendon. Okay. So let's look up the word hallucis. If we don't quite understand what hallucis is, we can always Google it.
Hallucis.
You want to Google the word?
That's a muscle. I know that.
Okay.
I've heard that. Extensor That's a muscle. It wasn't
Okay.
tendon. That's so it's in the musculoskeletal. But I can now. I'm gonna do what you say. Hold on. Oh, phone right here. Okay. I'm gonna spell that out to me, and I can, because I had to minimize. It's a tendon, right?
Mm-hmm.
Hallucis extender. Hallucis longus. I think that's how you. Tendon. Okay. Let's talk about the repair of it.
Mm-hmm.
Okay, let me look on Wikipedia and see what it is. Oh, and it's so many muscles. So many bones is a lot to the body.
It is.
More than what people know.
More than what people ever know.
It says it is a thin skeletal muscle situated between the tibulus anterior and the extensor digitorum longus.
Okay.
It extends the big toe and dorsiflex the foot.
Mm-hmm.
Okay, so it's like in the front, like the picture showing me, kind of. All right. Okay, let me get back to. All right, I'm back with you. So we're talking about some muscles.
Okay. So let's see here.
Genius above underscore and retracted medically and laterally, thus exposing.
Okay, so an incision of the medial and parallel to the extensor hallucis longus tendon. Now, hallucis longus tendon is the procedure that we're looking for. The incision, but it's an incision. It's an incision was deepened through underscore retracted medially and laterally, thus exposing the capsular structures below, which were in size and longitudinal manner approximately the length of the skin of the incision. The capsular structures were sharpened, underscored off the underlying osseous attachment, retracted medially and laterally using the osteomome and mallet. The medial eminence of the medial tarsal bone was removed and the head was remodeled. So it was remodeled. So it's incision and then it was remodeled with the Leisten bone forceps and the bell wraps. Okay, so it sounds like it must have been a repair. But let's look up. Okay, so we can't find hallucis under incision. Let's try to find the term itself. HU. Is it HU? HA. HA.
Yes, ma'am. HA. HA.
HA.
Let's see. HA. Okay, HALLUX.
Okay.
Okay, what it's telling me is C, great toe. So
very
guess
good.
what?
So there's a breadcrumb.
Breadcrumb.
That's the breadcrumb. You're learning the breadcrumb. Okay, so let's go to great toe.
Great toe. Let's see.
Now, your CPT book is what year?
2020.
2020. Okay, mine is 2018. Let me take a peek. Yeah, it's 2018. So mine is a little old.
All right. Oh, great toe. What about the great toe? That's the big toe. Let me see. Okay, great toe. Okay. So under here, but it was telling me the other terms with that.
Okay, so hellacious or hellacious longus tendon. So when they did the mallet and osteomome, the medial eminence of the metatarsal
phalange joint.
Bone. So on the sheet here, metatarsal bone was removed and the head was remodeled. Okay, so it may be between two. Okay, in my book I have 28750, but what does your book have?
Okay, yeah, but it's called a metatarsal phalangeal joint. 28750, right?
Yeah, but is that what your
That's
book
what my
has?
book is saying.
Okay.
Yes, ma'am.
Okay. So let's go over here. 28750.
Two 287. Okay, 28750. Arthrodensis, great toe, metatarsal phalangeal joint. I don't have anything extra under there. CPT assistant, December 96, 7, December 16, 8. And that's it, because you told me to always read in case it's giving me other instructions or other characters, like see this code and that. So I'm reading.
Right.
I don't see any of that.
28750. Do you see it?
Yes, ma'am, I have it. That's I have it.
Okay.
And it's under something that's called arthrodensis. I guess I'm assuming that must be term for great toe or dealing with the great toe.
Okay. So 287. Oh, I'm looking in the wrong area. No wonder. It's me looking at stuff crazy. Arthrodesis. 28750. 3750. Arthrodesis. Okay, but it doesn't mention anything about arthrodesis in here.
Let me see. Oh, you're talking about in our actual progress? No, I don't see that either. That term.
Yeah, it's not in the actual word. But when it says here that the medial eminence of the metatarsal bone was removed and the head was remodeled, so that sounds more like a repair or a revision or a reconstruction. So let's look under reconstruction. Let's go back to the end of the book.
Index, okay. And reconstruction?
Yeah. Look like they were trying to redo something with the person. Let's go to reconstruction.
Okay, reconstruction. And what's my other term? I gotta look for.
Hold on. I'm trying to find it here. Reconstruction. Trying to find it. Let's see. So it's either under reconstruction or repair. Oh, go under repair.
Oh, repair. All right. REP. Let me see. Mm-hmm. Okay, repair. I'm under that.
Now find Halix. Halix valgus.
Let me see. Okay, I see it. 28292, 28295, 28299.
Okay, so this was a repair. Okay, and I'm gonna show you where it says that, but let's go to 282. What did it say? 28292. Let's go there. Did you see it? Did you see it under repair?
Yes, ma'am. That's why I was reading what you just read out the last.
Okay. To go
28290. 28290.
28292. Okay, 28292. Go to 28292.
Okay, 28292. I have it.
Okay. Correction. Halix valgus bunionectomy with sesamoidectomy, when performed with resection of proximal phalanx base, when performed any method. Okay, so there were some changes made, and CPT assistant. So now it's telling you at the bottom of it, 282.282.93 has been deleted. 282.95 is out of numerical sequence. Okay, so 282. Look at your choice of answers on your answer sheet here. You have
back at the test question.
Back to the question. You have 282.98, and you have 282.92. You have 282.96, and you have 282.97. Okay, so the 282.98. Now, look at this. If you go back up here to 282.92, what we call that is the actual code of information.
The 28292.
See how it's indented more so over as a paragraph?
Yes, ma'am.
That's the actual code of information. But if you look at 282.96 all the way down to 282.99, it's indented over. Do you see how it's indented over versus the 28292? Do you see how the information is indented over? Take your ruler and measure it. You'll see what I'm talking about. Take you a sheet of paper. Okay, I'll do it like this.
Okay,
let me show you. How can I do this? Give me a minute. I'm going to show you. Make a ruler. I don't have a ruler, but I'll make one. Okay, I'm bring this book up here. Okay. So, do you see how 282? Let me see. Let me get it out the shadow. Well, let me see if it'll work. Okay. Do you see how the 282 up here, the information up here, 28292 right here?
Yes, ma'am.
Okay. Do you see how that information right here where my finger is, how it sticks out more than this information right here where my other finger is?
You talking about the stuff below it, right?
Yes.
Where your finger? Okay.
Okay. Now, this information here is more so over than this information here. This information, I'm gonna go over the beginning of this information. See how that
Okay, I know what you're saying now. That is more over. Yes, ma'am.
Okay. These are called standalone codes. Some of them are called standalone codes because their information, if they match what's described in the operative report, then you can use these if there's no further instructions to say that you cannot use these. If you can use these are known as standalone codes. If it's instructions that say that you have to have this to match with this, that means if you have to use this code to match with this code, or this code to match with this code, or this code to match with this code, then it is not a standalone code. It'll give you written instructions that you would have to use this code in conjunction with this code. You see what I'm saying?
Yes, ma'am.
Okay. So this has a little bit more. So let's read it. So 282.92 says correction helix. So there was some corrections made to this person's foot. Helix valgus bunionectomy. This was called a bunionectomy with sesamoidectomy when performed with resection of proximal phalanx base when performed any method. Now, if we were to use, say, for example, look at 282.96. This one says with medial metatarsal osteotomy method. In the case study here, this does not say anything about osteotomy. It says osteomized osteotome, but not osteotomy. Look at 28295. It says with proximal metatarsal osteotomy any method. 8297 with first metatarsal and medium cuneiform joint arthrodesis any method. It doesn't mention anything about cuneiform or anything about arthrodesis. With proximal phalanx osteotomy any method. Doesn't say anything with that. With double osteotomy any method. Doesn't say anything with that. So it is an actual helix vagus correction. So let's read back through the situation. A 59-year-old female was brought to the operating room, placed on a surgical table in a supine position. Following anesthesia, that surgical site was prepped and draped for normal sterile fashion. Attention was directed to the right foot. Hello?
I'm here. I'm sorry. I'm reading. I'm reading along on my phone.
Okay. I thought I heard a bell go off or something. Okay, I'm sorry.
No. You fine. I'm reading along.
Attention was then directed to the right foot, imagine picture foot, where using a number 15 blade, a 6 linear incision, a cut was made over the first metatarsal, dealing with the toes, metatarsal head, taking care to identify and retract all vital structures. The incision was medial and parallel to the extensor hallucis longus tendon. Okay, so what they said was, we're operating on this person's foot with this blade right here. And we're going to cut along the metatarsal head. And then we're going to cut around the vital structures, which is the nerves. The incision of the medial and parallel extensor hallucis longus tendon. The incision was deepened through subcutaneous, underscored, and retracted medially and laterally, thus exposing the capsular structures below. Capsules. That's dealing with arteries, nerves, different things like that. Capillaries, structures, which were incised in linear longitude manner and approximately through the length of the skin. The capsular structures were sharply underscored off the underlying osseous attachment, retracted medially and laterally using an osteotome and mallet. That's a hammer. The medial eminence of the metatarsal bone was removed and the head was remodeled. That means repair with the Leisten bone forceps and the bell rasp. The surgical site was then flushed with saline. So when you read this carefully, there was a repair being done to the hallucis longus tendon. So hallucis longus tendon correction, that was the procedure. That was the procedure right there in the midst of what we read. So we needed to understand, once we found the procedure, we needed to understand what was going on with that. So we read that there was an incision made, but yet at the end, it says the base of the proximal phalanx of the great toe was osteomized and approximately 1 centimeter distal base and exercised into it from the surgical site. There was no hemiplant implant used. So they didn't put a implant in there. and a Kirschner wire was used to hold the joint in place. So they went inside and did some sort of repair. They cut inside and they made some sort of repair. And then they were careful about going around the capillaries. And then after they did it, they put it together and closed it with a Kirschner wire. So they did some sort of repair. So that's how we got the inference that we needed to look under repair. Okay. So we have to think in those ways, because when you do actual coding, you're not going to have answer choices in front of you. You're going to have to know how to read through the report and know how to picture where to go. Okay?
Yes, ma'am.
Okay. All righty. So you got it. So our correct answer choice is B. 282.92. 282.92. Okay.
It's
282.92.
B. Okay. Okay, that one. That's the one we was concluding because we talked about the other one. So that's the correct answer, which is B, right?
Right.
Okay.
It doesn't, all these other standalone codes, 282.96 all the way to 282.99, these are standalone codes, but if you use any of this 282.96, you will have to then use 282.96 with the 282.92. But since the 282.92 spoke for it all, we didn't need to use any of the other additional codes.
Okay.
Okay. It takes a while and you'll get it. It takes a while. Okay. Let's look at number 81, the picture that I sent you.
Let me see. Hold on. Okay. That's the operative note, right? 81. It's about the angina.
Yes.
And coronary artery or disease.
Mm-hmm. So preoperative diagnosis and postoperative diagnosis. So their suspicion was angina coronary artery disease. Their postoperative diagnosis was angina coronary artery disease. So what they found within the situation was correct. What they found in the situation, it was correct. Okay, so let's read the procedure details. It says here that the patient was brought to the operating room and placed in a supine position on the table. That's the famous sideways position. After adequate general anesthesia, the patient was prepped with betadine soap in solution in the usual sterile manner. Elbows were protected to avoid ulnar neuropathy, and phrenic nerve protectors were used to protect the phrenic nerve. All were removed at the end of the procedure. A midline sternal skin incision, here we go, that's where they're cutting, was made and carried down the sternum, which was divided with the saw. Pericardial and thymic fat pad was divided. The left internal mammary artery was harvested and spatulated for anastomosis. Heparin was given. It was a blood thinner. The femoral popliteal vein was resected from the thigh and side branches secured using a 4-0 silk and homeo clips. The thigh was closed using multi-layer Vicryl and Dexon technique. The pulsavic wash was performed and the drain was placed. The left internal mammary artery was sewn to the left anterior descending using the 7-0 rolling technique with the Medtronic off-pump retractors. After this was done, the patient was fully heparinized, cannulated with a 6.5 atrial cannula and a 2-stage venous catheter, and begun on cardiopulmonary bypass, and maintain neurothermia. Medtronic retractors used to expose the circumflex. Prior to going on pump, we stapled the vein given off to the aorta. Then on pump, we performed the distal and anesmosis with a 7-0 running proline technique. The right side graft was brought to the posterior descending artery using a 7-0 proline technique. The daring procedure was carried out, but the bulldog clamps were removed. The patient maintained good normal sinus rhythm with good mean perfusion. The patient was weaned from cardiopulmonary bypass. Okay. The arterial and venous lines were removed and doubly secured. Prometine was delivered. Meticulous hemostasis was present. Platelets were given for coagulopathy. Okay, it's like coagulopathy. It's like coagulation. Coagulopathy. Chest tube was placed and meticulous hemostasis was present. The anatomy and the flow in the grafts were excellent and closure was begun. The sternum was closed with the wire followed by linea alba and pectus facius closure with running 6.0 vicryl sutures in the double layer technique. The skin was closed with subcuticular 4-0 Dexon suture technique. The patient tolerated procedure well and was transferred to the intensive care unit in stable condition. Okay, so we have all of these procedures to look at. So we're going to do a shortcut tonight for the sake of time. So I want us to look at B. Look at B. I want us to go straight to the code itself, which is the correct answer. But let's justify how it came to be what it came to be. Okay? So let's go to the first answer, 33533. 33533. 33533. 33533. 33533. Okay, so 33533 is underneath arterial grafting for coronary artery bypass. So let me tell you how it was grafting going on. I want you to go back to, okay, see where it says a midline sternal skin incision was made. Do you see that paragraph?
I gotta. Talking about under the actual code?
No. Go back to procedure details for number 81.
Oh, we're going back to the actual progress or operative.
Yeah, the operative report.
Oh, okay.
The inpatient operative report. This is an inpatient operative report. Because if you notice on an outpatient operative report, it's never going to give you. Well, it will give you that, but you're going to know the difference between inpatient and outpatient.
Because this is doing pre-operative and post-operative. That's
right.
True. It words things differently, so you are right about that. So.
Yes. Okay, now go to see where it says procedure details.
Okay.
Okay, I want you to come down to the second paragraph. It says a midline sternal skin incision was made and carried down through the sternum, which was divided with the saw. It's an electric saw. So they use an electric saw to get to the heart. Pericardial and thymic fat pad was removed, so they had to remove the fat pad that protect the heart. The left internal mammary artery was harvested and spatulated for anastomosis. Okay, so the left internal, so this is, let me show you. This is my left right here facing you. Internal mammary artery. So if this was my nipple right here, and it was this on a female or a male? They never said it was on a female or a male. Okay, so we just take it that it was a female. We'll just look at that. So if this was my nipple here, there are arteries all around my nipple, and there are nerves all around my nipple that blood flows through. Okay, so when they open me up in the middle here, they have to carefully open up, and they have to carefully move the left, what is that? Mammary artery over. If there's an artery, that's a major, how can I say, pipe of the bloodline you don't want to mess up. So when they moved it, they had to take an instrument to like move it over, okay, and hold it down. You see what I'm saying? They had to take a spoon and move it over, if you will, a spoon, and move it down out the way so they don't damage it. Are you picturing what I'm saying?
Yes, ma'am.
Okay. The pericardial and thymic fat pad was removed. Okay. Heparin was given. Now, you're probably wondering, what is heparin? Heparin is a blood thinner. Heparin helps make sure that while they're open and inside this person, while they're under anesthesia, they have to make sure that their blood does not clot or coagulate. If it clots or coagulate while they're inside the person, they got a problem, because circulation is not going to continue. So they got to do everything kind of quick and fast within a certain amount of time. But if they use heparin while circulation and while they're harvesting the arteries and the veins and moving them over, they're not breaking them, they're not cutting them apart, they're just moving them over. Okay. If they don't disturb the circulation and blood flow while they're doing this, then they have a good chance of the patient's survival rate. Okay. Heparin helps to make sure that the blood stays thin and it does not coagulate. Coagulation means that the blood will turn into gelatin. It'll turn into jelly. It'll have little specks of jelly. It'll just turn into a puddle of jelly. So with the heparin, it makes sure it stays smooth and it doesn't turn into jelly. Because the last thing that the heart surgeon does not want to happen is the person to get a blood clot. Okay? Look at the next paragraph. The femoral popliteal vein. Okay. The femoral popliteal vein. Let me stand up. Let me see if you can see. Let me see. Okay, well, best as I can. Okay, that's good. The femoral popliteal vein is right up in here. So they have to get a vein that is suitable to transfer it. They have to harvest it. So they have to cut it from here to here and transfer that vein quickly up to the heart, up to the area where they're operating on. Do you see that?
Yes, ma'am.
So that's called grafting. Okay.
Grafting, yeah. Okay, harvesting, grafting.
Harvesting, grafting. Okay. So once they cut that femoral, because this is the femur, femur, thigh, humerus, upper arm, humerus, femur, thigh, femoral popliteal vein. That's like in the growing area. Okay. So they had to take a big vein from there. That's what they normally would do. And they would reconnect, they would cut a piece, reconnect the veins down there in the femoral area, and that femoral vein that they taken and they put up here is suitable to put in the heart area, and they doing some sort of reconstructive surgery on the person's heart because they developed coronary disease. So you can Google and YouTube and find out what is coronary disease. And then I want you to also YouTube and Google angina and coronary coronary artery surgery. Okay.
You want me to Google now? You talking about the coronary?
No, on your time.
Oh, my time. Oh, okay,
at your leisure. At your leisure. I want you to YouTube that and look, just kind of study the procedure so you as a coder can picture what they're doing. So you can picture what they're doing. Okay. The femoral popliteal vein was resected from the thigh and side branches secured using a 4-0 silk and hemoclips. The thigh was closed. See, they went in and got it. Then they closed it. Closed using multilayer vicryl Dexon technique. The pulsavic wash was performed and drained was placed. So they have to make sure that when you cut into something, it's going to, they have to put a draining in place. I don't know if you ever seen a person that has surgery. They have a draining bulb attached to them and taped to them, surgically attached to them. So as they heal, sometimes they build up fluid. So to keep from building a fluid on the inside, it drains into this bulb-looking thing. I have to send you a picture. Okay. The left internal mammary artery was sewn into the left interior descending using a 7-0 rolling technique with the Medtronic off-pump retractors. After this, after this was done, the patient was fully heparinized. So they put that femoral artery up here to repair the damaged artery. Okay. And after they carefully surgically connect the cut artery of the old artery, they have to, how can I say, surgically repair and mesh the veins together. You have to use microscopic lens to really do that perfectly, so that the new and the old would mesh together like this. See my hands?
Yes, ma'am.
They'll heal and mesh together like this. But once they heal and mesh together like this, you have to have a draining bulb somewhere underneath it or within it, so that all the excess fluid, not infection, but excess fluid will drain off into this bulb. I'm going to show you what I mean in a minute. Okay. After this was done, the patient was fully heparinized, cannulated with a 6.5 arterial cannula and 2-stage venous catheter, and begun on cardiopulmonary bypass and maintain normothermia. Medtronic retractors were used to expose the circumflex. Prior to going on pump, we stapled the vein graft to the aorta. Okay. And sometimes these are staples that are biodegradable. Okay. So then on the pump, we performed the distal anastomosis with 7-0 running proline technique. The right side of the graft was brought to the posterior descending artery using a 7-0 proline technique. Okay, so they had to use a technique to make a graft of the arteries on the right side and graft it to the main artery of the repaired artery and bring everything back together to closure. Okay? I mean, are you picturing this? Do you have an idea now?
Yes, ma'am.
Okay, so this was grafting that was taking place. Okay, I'm gonna kind of jump around here. The anatomy and the flow in the grafts were excellent. I'm on the last paragraph, and closure was begun. The sternum was closed with wire following a linea alba and pectus fascia closure with running 6-0 vicral sutures in double layer technique. The skin was closed subcuticular 4-0 Dexon suture technique. The patient tolerated the procedure well and was transferred to the intensive care unit. So for shortcuts tonight, B is the right answer. I want you to look at that 33533.
335. Hold on.
33533. And this one says coronary artery bypass using arterial grafts, single arterial grafts.
It's 335.
33.
Okay, coronary artery bypass using arterial graft or grafts, single arterial graft.
Mm-hmm.
And then the other code, let me go to that. That's going to be
33517.
Okay, 33517 is coronary artery bypass using venous grafts and arterial graft, a single vein graft, list separately in addition to code for primary procedure.
Okay,
and
now
it has
go ahead.
Use 33517 in conjunction with 33533-33536.
Right. You see that coding rule right there? It was written already for you. So you already have that down already. So you're already using 33533 with 33517. Okay. And then 355572.
335. Okay, 33572. That's on the coronary endarterectomy. That means a coronary endarterectomy, open any method of left anterior descending circumflex or right coronary artery performed in conjunction with coronary artery bypass graft procedure. Each vessel lists separately in addition to primary procedure. And then we have use 33572 in conjunction with 33510-33516, 33533, and 33536. Okay. This one gave us a lot of breadcrumbs, but then it is to say, okay, use in conjunction with this. So you know, and if you do that, so you use this, that code, and then that one going in conjunction with this as well. Which you always did tell me that you gotta read everything that's up under. If it's nothing else up under there, but make sure you read it, because then it'll tell you other breadcrumbs of what else you need to do.
Right. Exactly. Okay, sweetie. I'm gonna let you do number 80 for homework. I'm getting a little tired. I'm sorry.
Okay.
And
no. You had a long day today.
Yeah, I did.
You are excused. I just appreciate you helping me. So
yes.
I can work with you.
Okay. So I'm gonna give you some homework though, okay?
Okay.
So do you see on the picture number 82 and 83?
Am I doing okay, wait a minute. 80. Oh, you're talking about on the second one. Okay, 82, 83.
Yeah, and the picture that I sent you?
Yes, ma'am. I can do 82, 83. Okay, and I need to have an answer when we meet again.
Yes, and I'm gonna give you a little bit more questions to do. Now, on the test itself, it has 6. Let me tell you what it has. Give me a minute. It has 6 domains. I'm gonna be right what I say. Yeah. It has 6 domains. So 1, 2, 3, 4, 5, 6, 7 domains. I'm sorry. It has 7 domains. So you need to be familiar with oh, you know what? Let me take a picture of all this, what you need to be familiar with. Let's see.
Yes, ma'am. You can text it to me. That'd be great. Yeah.
Okay, hold on. Questions, subject. Okay. Yeah, let me do that. Let me do that. Okay. These are the domains that you have to be familiar with. Okay. All right.
If you find in that book right there, I guess one with the external causes, that'll be a good one to, like, we'll answer these 2, but if you could find something with that, so I can
with the external
get a little bit more familiar with the accident ones.
Okay.
External causes, yes, ma'am. That'd be great.
Okay.
Because I'm not as, because when I in the class, I had a question that it had a scenario and it had a lot of different external causes to code for that particular patient. I was like, I haven't seen too many of that, but it's, that would be good.
I'm going to look for it.
Because there's even stuff that I didn't even think that was on there to be coded for, like fighting with a person, fall, or just different scenarios. Yeah, that'd be
good. Okay.
Yes, ma'am.
Let me read through it and see. And if I find any, I'm going to send it to you.
Okay. That would be great.
External causes. Let me write down my notes here. An operative report on external causes.
I thank you for all the information that you give me.
Oh,
so I'll know which way I need to go to.
Yeah, you're welcome. You're very, very welcome. You're very welcome. Okay, sweetie. So I'm about to text you a whole lot of stuff for homework, and we'll work on this next week.
Okay. It's around this time. Be good. Saturday, Sunday.
Yeah. Around this time on Saturday.
Saturday. Okay. That's fine.
Yeah. All right, sweetie. Thank you so much for everything.
You're welcome, and thank you for everything.
You're welcome. And if you have questions, please let me know, okay?
Yes, ma'am, I will.
All right.
Ms. Harper.
You're welcome. You have a good one too, sweetie. Bye-bye, honey.
Bye-bye.